A very happy new year to all my brothers and sisters and dear doctors. So whoever watching this video, may this year bring you good health, success in your exams and excellence in your patient care. So let's begin in this new year with new and very important and high yield topic, that is pulmonary edema. If you are seeing in emergency department in hospital, mostly you can see this type of condition, that is we call pulmonary edema. Okay, so in this video we are going to discuss from basic to advanced level and management, clinical features and pathophysiology and causes, risk factors and how to do follow up. Everything in this video we are going to cover. So without time waste, I am yours Medico Anand Kumar Jana, final year medical student. So without time waste, let's start. So here we can see one case scenario. In that case scenario, we will discuss about the patient, then after what medication we have to use and why. This everything we will discuss while studying our PPT presentation. Okay, so first of all, if you are seeing this patient clinical scenario, you can see here a 65 years old man presents with sudden breathlessness, pink frothy sputum, and the blood pressure is 180 by 100 mmHg, and we can see bilateral crepitations. In chest x-ray you can see bat wing appearance or bat wing pattern. So how we can find out that bat wing appearance means, here this is, you can see this x-ray. In this x-ray we can see like anterior posterior axis. Whenever we are seeing x-ray, we have to follow, like for interpreting that x-ray we have to follow some steps. Easily we have one mnemonic, that is we call RIPE. Means first of all we have to check that patient details and everything, that projection, then after that rotation, okay, that then in that patient x-ray is inspired or expired and everything we have to check, and the projection, it's like well projected or not, and the exposure, everything we have to check, and the previous x-ray, and we have to compare with new x-ray. Okay, then after we have to check the ABCDE, that is like airway and bronchioles and that curly lines and crepitations and cornea and some bones and that clavicle bones and everything. And then after we have to check consolidation or wheezing, for wheezing problems, that lines, infiltrates and masses and everything we have to check. So here if you are seeing this x-ray, this is anterior posterior x-ray. Here you can see some type of bat wing appearance. This type of appearance we call bat wing appearance. Okay, so this appearance if you are seeing means we have to suspect pulmonary edema. Same to same you can see in acute respiratory distress syndrome also, ARDS, but you can differentiate easily. We will discuss this thing while discussing about x-ray interpretation, and while discussing about bat wing appearance, that time we will discuss about how to differentiate pulmonary edema versus ARDS. Okay, so here you can see that patient like 65 years old man presents with sudden breathlessness, means dyspnea, and pink frothy sputum. If you are seeing like pink frothy sputum and bilateral crepitations in chest x-ray patient, the times we have to understand that patient have heart failure. In heart failure cases only we can see pulmonary edema. In that pulmonary edema also sudden breathlessness. Okay, so what management, what type of drug we have to use in first line drug? If you are seeing here we have some options, that is morphine. Morphine we can use, but mostly if patient getting like any anxiety attacks, that air hungerness or breath for reducing that respiratory tachypnea and everything, that anxiety and panic things, we have to use morphine. Okay, for doing respiratory depression. Next one we can check furosemide. Furosemide is diuretics, loop diuretics. So we can give furosemide. Why? This is the right option because in furosemide, that is loop diuretics, in pulmonary edema the fluid will accumulate in alveoli. So because of that thing the gas exchange will reduce. So that's why that option is furosemide. Why we are giving, we will discuss in management. Next one, antibiotics. If that is community acquired pneumonia or pneumonia cases, then only we have to use antibiotics. But here it's pulmonary edema, so you don't need to use antibiotics. Next one, bronchodilators. If any patient have asthma, narrowing of bronchioles, then only we have to use like SABA, salbutamol or albuterol or steroids. These are the things like hydrocortisone or montelukast. These are the things and bronchodilators we can use when it's become asthma. But here the patient have pulmonary edema, so the first line management is furosemide, loop diuretics, right? So introduction. What is pulmonary edema? Pulmonary edema is a condition characterized by accumulation of fluid in lung, interstitium and alveoli. What it will happen, if you are seeing this image, you can see the 65 years old man here. If you are zooming his lungs, you can see this type of bronchioles, and the bronchioles have some alveoli. The alveoli air sacs. Air sacs means it's like some ball type of pouch like structures. In that alveoli we can see some blood vessels. With that blood vessels only we can see gas exchange. If in this blood vessels, if you are seeing here in this alveoli, because of some factors, if any fluid accumulate or edema, then we can see the gas exchange will reduce. Because of the things we can see hypoxia condition, the impaired of gas exchange or reduced gas exchange. So because of that, body will not get enough oxygen, then the patient will go to hypoxic condition. If you are not treating, if you are not focusing on the patient can die also. So that's why this topic is very important, very high yield. Okay, so this is pulmonary edema definition. If you are seeing causes and risk factors of the pulmonary edema, in causes you can see the pulmonary edema is divided into two types. One is cardiogenic and non-cardiogenic. In cardiogenic, it's related to heart. In non-cardiogenic, it's related to like lungs or membrane and some other organs and structures and other problems. Okay, so in cardiogenic causes, if you are seeing, means it's like related to acute left ventricular failure. Mostly this is the most common condition with pulmonary edema we can see, because mostly the pulmonary edema we can see with acute liver failure. So next one we can see myocardial infarction. How? In acute left ventricular failure, what will happen if because of increasing the chamber, the left ventricular chamber, the heart is not pumping enough. So because of the thing, the backflow will happen. So the water, the blood will go to back to the left arteries. So because of the thing, the left veins, because of the thing, the pulmonary edema will happen in lungs. Next one, myocardial infarction. If any patient got myocardial infarction, that part got died. Because of the thing, the heart is not pumping enough, so that's why it can cause pulmonary edema. Next one, hypertensive crisis. If any patient have more amount of hypertension, the blood vessels will can constrict, so the lung will accumulate more amount of fluid. Next one, valvular heart disease. The blood is not pumping properly because of mitral stenosis or mitral regurgitation. Because of that thing also, the patient will get pulmonary edema. Next one, arrhythmias and fluid overload in chronic kidney disease and dialysis patients. Because whenever fluid getting more amount of accumulation in chronic kidney disease, we can see the fluid we can see in third space. So the patient will get ascites, and in lungs we can see fluid and everything. So these are the cardiogenic causes of pulmonary edema. So everything related to heart. Next one, you can see non-cardiogenic causes. In non-cardiogenic causes means it's related to some other factors like acute respiratory distress syndrome or sepsis and aspiration. In alcohol patients, mostly we can say after drinking more alcohol they will get regurgitation. Because of that thing, the alcohol will go to trachea and it will cause aspiration syndrome. Next one, high altitude pulmonary edema can cause non-cardiogenic pulmonary edema. Next one, acute pancreatitis, trauma and burns and neurogenic pulmonary edema. So these are the causes and risk factors of pulmonary edema. So pathophysiology. This pathophysiology is very important based on cardiogenic and non-cardiogenic. So in pathophysiology, if you are seeing this heart here, if you are comparing with right ventricle to left ventricle, the left ventricle will be like little more wide. Why? Because when for pumping blood to your whole body, the ventricle must be like wide, because for pumping heart, strong contractions. Okay, so here in cardiogenic pulmonary edema, what are the things will happen means, first the left ventricular end diastolic pressure will increase. These are the step by steps to how that cardiogenic pulmonary edema is happening. If you are seeing here, the increased left ventricular pressure and increased pulmonary venous pressure, next increased pulmonary capillary hydrostatic pressure, and the fluid will leaks into the interstitium, and the alveolar will getting flooding. Because of the thing, the gas exchange will get impaired, and the alveoli will because of the thing we can see hypoxia, then after respiratory distress. So these are the step by steps of cardiogenic pulmonary edema of the pathophysiology. Next one, you can see non-cardiogenic pulmonary edema pathophysiology. Here what will happen, if you are seeing this image, in lungs you can see some alveoli. In that alveoli attached with some blood vessels. These blood vessels will help to do gas exchange. But here, if the injury happens in alveoli capillary membrane, because of, we can see that condition like high altitude pulmonary edema we already discussed, or sepsis, or acute respiratory distress syndrome, or neurogenic pulmonary edema. So these are the things will cause this non-cardiogenic pulmonary edema. So here the increased the capillary permeability will increase. For example, dengue also have, because of increasing more amount of capillary permeability, it can leads to like tuberculosis or dengue, or these are the things will that HAPE. So these are the things will cause more amount of non-cardiogenic pulmonary edema, and the protein rich fluid will enters into the alveoli, and whenever the protein rich fluid enters into the alveoli, the surfactants will reduce. The surfactants is the main things will help to, like pneumocyte 2, the pneumocyte 1, these are the things will help to maintain the alveoli in like opening way. Okay, if the surfactants are decreased, then the alveoli will become collapse. So the air is not going to inside the alveoli, and no gas exchange, and it will cause impaired respiratory distress or hypoxia. Okay, and impaired gas exchange. Here the decreased surfactants and the alveoli will collapse, and it will lead to hypoxia. Okay, so these are the non-cardiogenic pathophysiology, like step by step of pulmonary edema. Okay, next one, clinical features. If any patient coming to emergency department with pulmonary edema, we have to do physical examination. In physical examination, first we have to do inspection, then after palpation, then after percussion, then after auscultation. So if you are seeing signs in patient, we can see like in vitals way, we can see tachypnea and tachycardia, and patient will be like hypoxic condition, like reduced saturation, oxygen saturation like less than 94. Okay, so and if patient coming with cardiogenic pulmonary edema, you can see bilateral basal crepitations. Okay, crepitations means this type of sounds you will get if you are using your hair to do move like this, you will get some crepitation sounds. So that type of sounds you will get in auscultation. So next one, in cardiogenic cases we can see S3 gallop sound. Next one, if in fluid overload patients, you can see in right side, you can see jugular venous pressure will increases. Okay, so and sometimes if patient have shock, the patient will get cold clammy skin. Okay, cold skin you will get. So these are the signs of the pulmonary edema. So symptoms, patient will come with severe dyspnea, means difficulty in breathing. Next one, orthopnea. Whenever the patient is trying to stand, they will get breathing related problems and they will fall. Next one, paroxysmal nocturnal dyspnea, means the patient will persistently night time they will get difficulty of breathing, because of the thing they will get up. Next one, cough with pink frothy sputum. This is the symptom we saw in clinical scenario. Okay, so cough with pink frothy sputum and severe dyspnea. So chest tightness, because of that impaired of gas exchange, the patient will get a chest tightness and breathing related problems. Next, because of the thing, anxiety and air hungerness. Okay, so these are the symptoms of pulmonary edema. Next one, how we can do investigation. What are the blood workups we have to do? Everything we are going to discuss here. First of all, imaging. In imaging, we have to do chest X-ray. In the chest X-ray, we can see bat wing appearance and clear lung fields. If you are seeing this image, you can see here, this is the X-ray. In that X-ray, you can see bat wing appearance. You can see here, this is the bat wing appearance. And sometimes if patient have like heart failure or dilated cardiomyopathy, the heart size will increase. So we can see like cardiomegaly, and we can see some clear lung fields. The lung fluid will be like clear. Okay, if that lung field is blunt, means we have to suspect that is pleural effusion. I already made this video about pleural effusion. If you didn't watch, please go and watch, and you will get more idea about pleural effusion. So in pulmonary edema, you can see cephalization also. The cephalization will reflect an elevation of left arterial pressure. Here it will reflect the left arterial pressure. Okay, so cephalization. If patient have congestive heart failure conditions, you can see some curly lines. You can see here, this is the heart failure patient. So this is the curly B lines. Next one, air bronchogram and pleural effusion in severe cases. Okay, so these are the imaging like chest ray findings we can see in pulmonary edema. Next one, for diagnosis of thoracentesis, for next one, sorry, this is the mistake. So in blood workup, we can check like saturation. In that saturation, the less than greater than 95%. Okay, next one, we can do ABG. In that ABG, we can say like hypoxemia. The partial oxygen will be like 80 to 100 mmHg. If you are doing ECG, in that ECG, you can see like arrhythmias or myocardial infarction. Okay, if it's normal, means normal sinus. If any patient have cardiogenic pulmonary edema, you can see the BNP, B natriuretic peptide, will increase. It must be like less than 100, but it will increase. Next one, we can do echo for checking ejection fraction, because in heart failure patients, the ejection fraction will reduce. Okay, if less than 55 means we have to suspect that is heart failure reduced ejection fraction. Okay, next one, we can do PCWP. In this test, whenever you are doing it in cardiogenic cases, the pulmonary capillary wedge pressure will increases. So that is when it's increased like more than 12 mmHg, then we have to suspect that is cardiogenic pulmonary edema. So how we can differentiate cardiogenic and non-cardiogenic pulmonary edema means, in cardiogenic the BNP will increase and the PCWP the pressure will increase. In non-cardiogenic, then PCWP will be like normal. Okay, so these are the investigation things. Next one, we can see like how to do diagnosis and how to do severity grading means, in diagnosis we can do clinical physical examination, then after chest X-ray, then after in severe cases ABG, and we have to identify the cardiac and versus non-cardiac. With physical examination we can find out, or with the BNP or with PCWP we can find out. Okay, in how we can do grading of severity means, we have mild, moderate and severe. In mild cases you can see dyspnea and on exertion. In moderate cases you can see dyspnea means difficulty in breathing at rest also. In severe cases we can see like respiratory failure or shock. Okay, so these are the things. Next one, management. In management we have some goals, that is we have to improve oxygenation and we have to reduce the preload and afterload, because in cardiogenic cases the blood is not pumping properly. So because of the thing, the patient got pulmonary edema. So we have to reduce preload and afterload with medication, with pharmacological management. Next one, we have to treat underlying causes. We already know about cardiogenic causes and non-cardiogenic causes. So we have to treat that cause with based on that condition, based on that medications. Okay. Next one, how some general methods we have to follow. Whenever patient have pulmonary edema, we have to give that patient position like semi-fowler position or fowler position like 90 degrees and 45 degrees. Next one, we have to give oxygen therapy. I already explained about oxygen therapy and how to follow that ladder and everything in pleural effusion. Then after we have to neutral that saturation like above 94% saturation. If it's going to less than 94%, we have to give oxygen supplementation. Next one, we have to restrict the fluids. If patient have like cardiogenic congestive heart failure or chronic kidney disease, the fluid restriction is very important, and DASH diet means less salt also very important. And we have to continuously monitor saturation and ECG and blood pressure. Okay. Next one, in severe cases we have to send the patient to ICU. So in management, pharmacological management, we have first line management and second line management. In first line management, we have to focus, first of all, in first line management, first important drug, that is furosemide, loop diuretics, for draining, for extricating that fluid and everything from the lungs. So first of all, first drug is furosemide. I already told about loop diuretics. How much dosage? 20 to 40 milligram intravenously. Here in GPHC we are using stat like 60 milligram, then slowly based on patient condition we will reduce. Next one, for what purpose we are using? For pulmonary congestion, and we have to check always the blood pressure, and the furosemide we can increase hypokalemia, so that's why we have to check electrolytes also. Next one, nitroglycerin. The nitroglycerin is the main drug will cause vasodilator. We can use 5 to 10 microgram per minute, and it will increase intravenously we have to give, and we have to titrate based on the patient condition. The indication will be like it will reduce the preload, and we have to monitor the blood pressure, because it can in hypotension cases we can't give nitroglycerin because it will increase more amount of severe hypotension and the patient can die. Okay. Next one, oxygen supplementation, like for supportive treatment 5 to 10 liters per minute, and you can use mask, and we have to give, if based on that patient condition we can use nasal cannula prongs. In acute, then after hypoxia, if saturation, and we have to focus, the patient must be go to saturation will be more than 94%. In second line management, we can give morphine to reduce that anxiety and difficulty in breathing. Morphine is opioid, we can give 2 to 4 milligram intravenously for using for symptoms like anxiety and panic and tachypnea, this type of conditions. For reducing, we have to give morphine. Okay. Next one, ACE inhibitors. The ACE inhibitors is a very good drug for reducing afterload. Like we can use enalapril because less side effects we have. Intravenously we can give for left ventricular failure patients, and we have to avoid in shock patients. In severe cases we can give like CPAP or BiPAP and ventilator support. If patient like moderate to severe pulmonary edema, then we have to give ventilator support, and we have to avoid if the patient have hypotensive, because if you are giving more amount of ventilation and oxygen, the patient will get more amount of hypotension. Okay. So that's why thing is, if you are giving more oxygen also will cause body will affect. So that's why based on patient condition, based on patient requirement, we have to give oxygen supplementation. So here, based on severity grading, we have to treat the patient. So if you are seeing here mild cases, mild, moderate and severe. In mild cases, the patient will get dyspnea when they are doing exertion. So in that cases, we can give oxygen supplementation and oral diuretics like 20 milligram of furosemide, and we have to treat the cause, and we can send the patient. So this is the in mild pulmonary edema cases. In moderate cases, what we have to do? In moderate cases, we can give intravenous diuretics and nitroglycerin, then after we can give CPAP or BiPAP. Next one, in severe cases, we have to send that patient to ICU department, and we have to do intubation, and we can use inotropes and vasopressors. So in severe cases, we can use dobutamine, and for hypovolemic things, we can give vasopressors like norepinephrine. So these are the things we can give. Okay. So what are the complications we will get with pulmonary edema? Respiratory failure, cardiogenic shock, arrhythmia, acute kidney injury. Whenever we are giving diuretics in pulmonary edema, we have to check acute kidney injury, like we have to check creatinine levels and urinary output, because we have one criteria, KDIGO criteria. That criteria will help to diagnose the acute kidney injury. Okay. Next one, in severe cases, patient will get death also. So how to do follow up? We have to check daily weight, because after giving diuretics we have to check weight, because more amount of urine will go out, so the fluid will decrease in our body. So we have to check weight for that patient. Next one, we have to check input and output and electrolytes, because we used diuretics, so it can cause hypokalemia, then it can cause arrhythmia, this type of things. So next one, renal function test we have to check, and we have to repeat chest x-ray. If patient is not drinking any smoking, then after 6 weeks we have to check. If patient like smoker means, we have to check every 3 weeks or 2 weeks. Okay. And we have to do echo follow-up if patient is congestive heart failure. Okay. So these are the things in pulmonary edema. We discussed about like case scenario, and what pulmonary edema, what it will do, and what are the pathophysiology, clinical features, and investigations and management, complications and follow-up. Okay. So in this video we covered everything. If you have any doubt, you can ask me in comment section. So if you didn't subscribe my channel, you can, this video is useful for you, you can like, share and subscribe. And if you have any I have to discuss, if any topic if you want to discuss means, just message and comment. So based on that we will discuss that video. Okay. So another time, wish you a happy new year, and we will meet in our next video. Till that time, take care. Bye bye.